Okay, so let's talk about active. Now, active range of motion is utilized in the patient who is ready to gain, improve MIO, maximum intraoral opening, okay? Or MJO, maximal jaw opening. So when our patient is ready to do this, they may be post-treatment, post-radiation, and we're looking around that 3 to 6 month mark where we're typically seeing the worsening of the trismus and those side effects kick in. But for some of our patients, that's oftentimes even sooner, 6 weeks post-treatment, 6 weeks post-radiation. Now, my active range of motion, those are going to engage the muscles of mastication, and they are going to work towards improving the oral opening, okay? So we're specifically addressing masseter, pterygoids, and anterior belly digastric, right? So let's show how we can utilize the same tools in passive movements to work towards actively contracting, all right? So here we go. So my active movements are going to look like I'm the therapist. I tell my patient, I want you to resist against me. Try to resist the band. So as I place this TheraBand in their mouth, again, the color is specific to the patient and what you're trying to achieve as the clinician. I'm going to hook it on their lower dentition. I'm going to tell them, try to close against me, and I'm going to pull down. As my patient is working to close and I am pulling down with resistance, we are actively contracting masseter and pterygoids, okay? So I need you to be able to kind of consider what we're working towards and what our patient's deficits are and when would we utilize specific devices. Now, how many times do we do that? It depends on your patient, okay? And it depends on their pain tolerance. You have to be utilizing that Omni scale of effort and the pain tolerance. Remember, trismus is individualized. Next thing, how would I utilize the ARC-J to actively contract musculature? Well, I'm going to have my patient place the ARC-J in their mouth, bite down, and hold, okay? Actively engaging those muscles of mastication. And our goal in active range of motion is to improve functionality. All right, that's very specific. We're also working to change the muscle fibers and to try to engage improved movement and allowing improved function of chewing, speech, etc. Okay, so here we go. They place it in, pinch together. All right. Now, these muscles those muscles are engaged, okay? That's an active movement. Now, the repetition, the frequency, and the duration of that hold, so how long do they hold it? How many times do they do it? Those are all specific to your patient and their pain tolerance, okay? So when we're utilizing a device and we need to determine when can we use a device for active movements, with the specific goal of I'm now working to rehabilitate my patient and improve their oral opening. This is with physician clearance, surgical clearance, and active movements has a very big goal of improving functionality. The patient is able to tolerate the passive movements. We may have even considered coupling manual therapy with these movements, and manual therapy can be coupled with both passive and active movements, okay? So you as the clinician guide when are you going to select manual therapy. So I hope that in comparison, there are additional active movements that you can work with your patient, but I really wanted to clarify passive versus active. When might I choose one or the other? Because there seems to be a lot of challenges as to what do I do and how do I know when? And the reality is everything we do is number one, guided by the physician. Our ear, nose, and throat surgeons, they are our leaders and guiders. But number two, we collaborate with them to say, hey, what are your thoughts on this? I think the patient may be ready for active movements. How do you feel about that? And then we obtain the orders. And then we individualize the treatment based on the pain, based on where the patient is at in their recovery. All right, awesome. We'll see you soon.